Sir, can we start with Dr. Mayank? Yeah, please, Dr. Mayank.
So good afternoon, everyone. I'll be briefly talking of the genetic makeup of retinal dystrophy patients that we're seeing in India, their clinical features, comparing them to mutations with those seen in other parts of the world, and then briefly discussing our work on CRISPR gene editing for patients with retinal dystrophies. So sequencing patients with retinal dystrophies, one of the important things that came out was that we were seeing three more common genes that were being involved. Specifically speaking, the AIOS2A gene, the circle gene, and the PROM1 gene in our patients. And the other mutations were in these CYP4V2 gene, CHM, PDFXA. But what I want to emphasize was that the incidence of a particular mutation was found more common in certain communities, which points towards the higher, which is likely because of the higher incidence of consanguinity. And specifically, the circle gene mutations we were seeing solely in the Agarwal community, which could potentially suggest a founder mutation effect. So clinical features of these patients, patients with the circle gene mutation, typically had pigmentary changes in the periphery with some degree of macular involvement. Vision typically ranging from 612 to 618 at presentation, typically in the second decade. But that said, there were also patients who had a paucipigmentary appearance, reported by Dr. Sen et al. As well, and which had more of a central macular changes, but not as many of peripheral pigmentary changes. These patients, unfortunately, did have much significant vision loss, which ranged from typically finger counts at 2 meters and to hand motions close to face. So a very stippled autofluorescence that we're seeing, and a significant foveal thinning in this patient with circle gene mutation. The other common mutation, this is a patient with a circle carrier with no changes in the fundus. Another common mutation we saw was patients with AIOS2A gene mutation, and typically, again, presenting in second and third decade with vision loss to the order of 612, 618 vision, and along with that, of course, sensorineural hearing loss. Another mutation which I want to emphasize was on PROM1 gene, wherein the patients, if they present by the first decade, there's a 6/9 vision, but significant macular involvement if a patient was to present by the fourth decade. So the clinical findings point towards how the gene mutation would progress in terms of vision loss. So some other gene mutations that I want to emphasize on, but now moving to the CRISPR aspect of it. So CRISPR essentially consists of this gene editing tool, which is largely the Cas9 protein, and along with that, the RNA strand, which is called the guide RNA. And this guide RNA, along with the Cas9 protein, attaches to a particular path of DNA, and that can be used to cause double-stranded breaks in the DNA. So once the double-stranded breaks are done, then the normal repair mechanism of the cell allows for the correct mutation to be introduced. So while this is a very effective gene editing tool, but that said, it has certain limitations. One is that there can be off-targets, that's cuts in undesired areas of the genome. Not all cells may undergo editing, that's the editing efficiency of it. And the guide RNA always recognizes whenever the DNA sequence is next to something called as a protospacer adjacent motif, which is typically a sequence such as GAG or a CAG sequence. So therefore, CRISPR underwent a few modifications, specifically speaking, base editing, wherein a deaminase domain, which is right next to this Cas9 protein, is able to deaminate a cytosine to thymidine or an adenine to guanine. So therefore, point mutations can be more precisely targeted using this. Another modification is prime editing. And in this, a reverse transcriptase domain is added to the Cas9 protein. And further now, even RNA editing. So for retinal dystrophies, CRISPR is most relevant for large genes wherein you can't do a gene packaging, as well as dominant and gain of function mutation. So all the patients that we were seeing with these retinal dystrophy mutations, we looked at which many of them had point mutations for base editing. So 58% of them had that. And about 14% of all of the patients were targetable using the CRISPR base editing. So we chose the AIOS2A gene mutation with point mutations in both exon 19 and 63, and further analyze whether we can do a CRISPR gene editing. We generated patients' iPSCs, and then thereafter did the gene edits in the patient's iPSCs. We achieved editing efficiency of about 25%, and now are moving towards the animal studies. So to conclude, with CRISPR, the challenge remains variety of mutations that are seen in IRDs. So therefore, there's no cookie cutter technique that you can apply on all patients with retinal dystrophies. So while it is a powerful tool, there are often very many off targets, and therefore CRISPR modifications have an intense role in doing a more efficient editing. Thank you.
Thank you, Dr. Mank. Now I would like to invite Dr. Apurva for her next talk on intraoperative fluorescein angiography for delayed postoperative vitreous cavity hemorrhage.
My topic is intraoperative fluorescein angiography in delayed postoperative vitreous cavity hemorrhage, or POVCH. My slides are not going forward. Yeah. So what is POVCH? It is a dispersed cavity hemorrhage post-vitrectomy for PDR or RVO or vasculitis. In the early immediate post-op, it could be because of clot dissolution or oozing stumps, whereas in the delayed post-operative period, it could be because of progressive neovascularization, traction, or anterior hyaloidal fibrovascular proliferation. For dense VCH with persistence, we do a vitreous lavage with endolaser to the skip areas, retrolental blood clearing, base shaving, cryo to the ports, gas or silicone oil tamponade, and most of this is based on surgeon's discretion. We feel that all these steps could be over-treatment, whereas just a fluid air exchange could be an under-treatment. This reminds us to apply the Goldilocks rule to do as much as necessary with as little as possible. We wondered if IOFA, or an intraoperative fluorescein angiography, could enable tailor-made treatment in eyes with POVCH undergoing lavage to avoid under or over-treatment and potentially reduce recurrences. We included eyes with dense POVCH post-diabetes or vein occlusions and at least 8 weeks post-surgery, post-vitrectomy with a minimum follow-up of 6 months. This is the accessory filter holder of the Alcon Constellation Vision System, this one, and we placed a blue filter, a 14 mm in diameter. I think I have the wrong PPT. I uploaded something else. This is the wrong PPT.
I don't think she can. Maybe Apurva, you can go to the preview
I have
room
done
and
that, sir. Both things I have done.
we
I have
will-
uploaded online also and.
What we can do, Apurva, that the next speaker
Yes,
can present.
thank
you.
you.
Can amend your presentation.
Thank you, thank you.
Then can you call Dr. Ajay?
Um, uh,
We will call upon Dr. Ajay Arora for presenting a new safe Avastin puncture assist device. And Apurva, you go to the preview room and come back. We will allow you. Okay? No problem. दो presentation दिया
She says few the images she has deleted. So updated presentation.
It is true, but वो old presentation भी रह गया है.
Correct, yeah, exactly. You must have opened all.
If you give two presentations, automatically they will stay and the old one will.
Thank you. Honorable Chair, can I have my first slide, please? इससे पहले, can you please go back? These buttons are not moving here.
No, try now.
I think with move, sir.
Good afternoon, Honorable. Can I change myself? Honorable Chair, dear friends, I'm talking on a new safe Avastin puncture assist device. So we are aware that particulate matter can get into parenteral solutions and it can cause impairment of circulation, blockage of blood vessels, damage to the organs, including phlebitis. These particles can be more than 50 microns or can range between 2 to 50 microns. Whenever we puncture a wire through the rubber, a coring occurs, and it's been shown that it can be as high as almost 50% of the time the rubber is punctured, versus depending on whether a blunt or a sharp needle is used. We have heard of this famous statement, Avastin does not blind people, it is people who blind people. And there the Braun made a mini spike device through which these syringes were used, and now we use this red colored needle with a 5 micron filter. But can you have a microparticle going into the solution which you are not aware of? 80% of the ophthalmologists in India still use Avastin despite the availability of biosimilars. So it is important to understand what can go wrong in your Avastin puncturing methods. What is this paper about? When we go through a rubber stopper of a vial with 26 or 30 gauge needle, do we go rubber? The answer is yes. When we use a 5 micron 18 gauge needle to remove drugs from like Razumab, Eccentric or Eylea, can we still have a coring? Yes, it will be less than 5 micron in size. Are there ways to reduce this coring? So whenever we puncture any vial, whether it's Avastin or any other vial, we can go through any of the parts of the lumen. It could be in the center or the sides. But if a coring occurs, we can have an aseptic endophthalmitis, and the cause could be actually the coring of the device. So I went ahead and made a new puncture device, which you can see there are 8 holes. There are 2 circles. The outer circle has 8 holes. The next circle has 4 holes, and there is a central hole in the center, and there is a notch on either side, N1 and N2, and there are 2 screwable handles. So this N1 and N2 coordinates with the red line on the Avastin bottle. So if I move from N1 to N2, I move the position of the holes, and that way I can get in with N1 13 punches and with N2 12 punches. So I can get 23 punches of a vial without going through the same hole every time, and that is very useful. I'll show you why that works out well. So I did this study in IIT Delhi, and we took 23, 26 and 30 gauge needles. We took bottles which were of the Avastin bottles which were cleaned with deionized water, and next we injected the deionized water into this bottles, and from there we took out with a micropipette on well plate, and these were then examined under the microscope for any particulate matter, and following that we did a scanning electron microscopy to see if we had detected any coring. This is the principle of scanning electron microscopy, by which we can actually chemically interpret what particles are there. So this is the table which shows 23 gauge needle without a pad, 23 gauge needle with a pad, 26 gauge needle with and without a pad, and similarly 30 gauge needle with or without a pad. You will see that when I'm going with the 30 gauge needle with the last table, I don't have a pointer here, with the last table with an A pad, there were no particles seen which are even less than 2 microns in size. So this clearly shows that if you use APAD with a 30 gauge needle, so this is the scanning electron microscopy images with a 26 gauge needle. Without APAD, we had particles of 8 to 10 microns. Then we had 23 gauge needle with APAD with rubber particles of 5 to 10 microns. And this is with 26 needle without APAD, 2 to 5 microns. And as we go through the 30 gauge needle, without APAD, we had a few particles, but with APAD, there were hardly any particles seen. Then we analyzed the chemical composition. We found that the rubber particles which was there in the rubber cork and the corings was exactly same, which means that the rubber corings which were detected in the deionized water were actually coming from the rubber cork. So what is the use of this particular study? It can be used with Avastin all over the country. It can also be used with any other vial like a botulinum toxin vial where corings can be made, and therefore it might be useful. And the next project for me is to use this coring, inject in animal eyes and see if they cause inflammation. Thank you.
Should we go back to Dr. Purva?
Thank you.
So Dr. Dr. Purva sir, or okay. Yeah. I would like to invite Dr. Aditya Maitre. He's going to talk about real sequelae of peripheral avascular retina case series.
Can I start? Yeah.
Slides, please.
Yeah, good
Yeah.
afternoon. So as we know, slides are not moving. Can you reset the timer, please? Can you reset the timer once? Yeah. So as we know that the common causes of peripheral avascular retina could include either physiological, which is secondary to high myopia, prematurity, FEVR and related retinopathies, Coats disease and PFV. So we did our own analysis of our documented cases of PAR with good imaging documentation, and we could see that the etiologies are similar to what I just mentioned. So I would just like to highlight some of the interesting cases here. Case 1 was this 10-year-old boy with history of extreme prematurity. Right eye had a ROP sequelae-like picture with atrophic retina and CRA patches. It was the left eye, which was a good eye, which has now developed reg RD, as you can see, with multiple breaks in the avascular retina beyond the old bridge tissue. Now, this boy did well, fortunately, with the buccal surgery, and the retina settled. Case 2 was a 21-year-old girl with decreased vision since childhood in both the eyes, and she had a history of prematurity and intellectual disability. The anti-segment showed axon-filled anomaly and an early PSC in both the eyes. But the fundus picture in the right eye showed these fibrotic bands in the vitreous connecting to the retina, some sclerosed vessels, an active VPT lesion, vasoproliferative tumor in ITQ with exudation, and significant amount of PAR with vitreous condensations. This was very well highlighted on the FFA, showing the PAR and the leakage from the VPT. The left eye was even more drastic with dense these fibrotic bands causing traction, significant chronic exudate in ITQ from an old VPT lesion, and a peripheral avascular retina. Additionally, this child had a history of cleft palate surgery done and had dental anomalies. So we were not just looking at a ROP sequelae here, although there was a history of prematurity. So we did because of these features combined, did not make the sense in terms of prematurity. So we did a genetic testing, and we could get a LRRC32 mutation, which is a TGF beta receptor gene coding mutation. And this, to our surprise, was reported to have an exact picture in the previous literature in terms of proliferative retinopathy and systemic features similar to what we saw. Then this case 3 was just a 16-year-old boy with Coats disease and an active VPT lesion in ITQ, and this is well highlighted on this FA image with PAR, telangiectasia, and the leaking VPT. And he did well with the cryo and to the VPT and peripheral laser. This case 4 was interesting. A young myopic girl with just came for a routine examination for myopia, and she said she had a history of barrage laser done to the right eye in the past. But as you can see, there are clear features of FEVR with dragging of temporal arcade vessels, peripheral avascular retina, these fibrous NVs in the periphery, and a VPT lesion in ITQ. So this was just not a high myopia, and the FFA beautifully highlighted the leaks from the NV and the VPT lesion, and the PAR also was well highlighted. Even the left eye had signs of FEVR with PAR seen on FFA. So finally, this case 5 was a 13-year-old girl who presented with decreased vision in the right eye for past 6 months. She had a syndromic facial appearance and nystagmus in both the eyes. When we saw her, the right eye showed a chronic retinal detachment, inferior retinal detachment with SRG bands, and some CRA patches at the macula. The evaluation under anesthesia showed these, the temporal periphery had this pre-retinal fibrosis with overlying vitreous condensations, producing retinal folds and schisis, probably causing the RD. The left eye had a similar CRA-like patches at the macula, symmetric, and the periphery showed these fibrotic NVE and PAR beyond that, which was well highlighted on FFA images. And to add to the confusion, there was the ultrasound picture showed a nanophthalmic appearance with extremely short exit length and increased RC thickening. So this was an atypical combination of FEVR-like features with nanophthalmos, which we have not seen before. So we advised genetic testing, and also the right eye did well with post-buccal surgery, and the retina settled well. However, the genetic testing did not reveal any likely or pathogenic or likely pathogenic variant. So the take-home message is that when we see a peripheral avascular retina, we should have a thorough history taking, and also should have a both detailed systemic as well as ophthalmic evaluation. And genetic testing can be considered in cases where the diagnosis is uncertain or where the features do not add up to a expected diagnosis. And most importantly, with the growing group of people with the increasing use of anti-VEGF monotherapy in ROP, there is a rising population of children who are growing up with a peripheral avascular retina, and they will need a good routine indirect ophthalmoscopy for detecting these PR-related complications early. And since these children do not really cooperate well for peripheral exam, there is the role of additional wide field imaging, where, as you can see here, without the wide field examination, the findings can be easily missed. Thank you.
Thank you, Dr. Aditya. Can I call Dr. Naman Sani for his presentation?
AV team slides. Slides. Do you have it in laptop? They can connect your laptop over here if you want. Yeah, please. AV team, please connect the laptop over here. Please connect.
Whether your presentation is there or not, because we cannot connect everyone's laptop. Again, a lot of time waste.
Can I have the presentation? Good afternoon, everyone. I'm here to present the 4-year long-term follow-up. No, this. So, I think this is not the. No. Okay. Can you just restart? First slide, please.
First slide.
Oh, yeah. No, I don't think so. This is VLSI. That is written AIOS. No, that is not the thing.
आपने नया अपडेट किया था क्या?
हाँ,
वो तो उसमें रहेगा सर, दूसरे इसमें फाइल में रहेगा वो.
निकाल दीजिए.
सब निकाल दो.
No, it is there, sir. I have uploaded.
सर देखिए.
Yes, that's it. I can start, sir. So, good afternoon, everyone. I'm here to present the phase 2A open label study, long-term follow-up after intravitreal MCO10 in patients with advanced retinitis pigmentosa. So, synthetic opsin that restores vision has already been published of a study, and you can see there are more than 3,000 mutations in RP, which is being caused by the patients with retinitis pigmentosa, and every gene cannot be addressed. So, the answer is a multi-characteristic opsin, which is an biogenetically engineered ambient light sensitive protein, and it can target each and every gene. And it is just injected through an intravitreal injection, and the target is bipolar cells, which is being converted to photoreceptors. And this was the timeline. The inclusion criteria was just perception of light or hand movement in the injected eye, and not better than counting finger in the fellow eye. All the patients are followed up till 52 weeks, And at the end of the study, you can see the primary endpoint included the side effects as well as efficacy of the drug. And all the patients now are in 4th or 5th year post-injection and followed up. And this is the all the features of the 11 patient which undergone genotyping. And you can see the optical coherence tomography confirming lack of outer nuclear layer, and functional measures of the patients are baseline with a non-detectable signal on ERG, and Humphrey showing almost loss of total visual field. The high dose group, which received 10 to the power 7 vector genome per ml dose, showed a significant increase in the visual acuity, which is, as you see, the p-value is less than 0.03. And there was a substantially clinical relevant improvement in NEI FEQ subscales, which with both vision-specific dependency subscale as well as distance activities. And the long-term follow-up shows limited intraocular inflammation after 4 years of follow-up. And the results shows a favorable safety profile was observed through 4 years of MCO-treated subjects, and transient intraocular inflammation and IOP rise in few subjects resolved with minimal intervention, and there is no retinitis, choroiditis, or vasculitis or hypopion in any of the patients, and there is no decline in visual acuity due to MCO treatment in contrast to the natural history of the disease, and substantially in clinical relevant NEI VFQ score improvements was also observed. The long-term follow-up at 4 years also showed dose-dependent improvement in the high dose group, which was still persistent after 4 years of follow-up also. So based on this, the initial study, they have conducted a multicentric trial in USA at 6 centers, which showed that MCO achieved primary and secondary key endpoints with statistical significance and no side effects. There they have extended the study for the initial 52 weeks showed a good result, and they have extended till 76 weeks in all these 6 centers, which also showed a good improvement in visual acuity without significant side effects or IOP rise. So to summarize, the LAF2 study in RP after MCO injection in phase 1-2A showed that MCO is well tolerated with no reported serious adverse effects. There are no anterior chamber cells or flare, vitreous cells or haze in any of the subjects even after 4 years. No subjects required medication to treat ocular adverse effect at the end of 4 years, and the benefit of treatment effect was observed through improvement from pre-treatment baseline in quality of life assessment activities, daily living using NEI VF25 score. And this initiated a biologic submission for appliance in US FDA, and we are expecting the drug to be available by end of 25. Here is a real life patient, subject number 003, how the patient is able to read the letters in front of my room, and this shows a real life scenario following VMCO injection. And I would like to thank all my team for all those supports during the last 8 to 10 years. Thank you very much.
Good afternoon, everyone. I have no financial disclosure. The title of my study is Assessment of Postoperative Pain with Local Dexmedetomidine in Patients Undergoing Scleral Buckling. So, scleral buckling, as we all know, is indicated for rhegmatogenous retinal detachment, which involves handling of the muscles, ocular tissue during the surgery, and indentation of sclera, which results in postoperative pain and discomfort. So, the purpose of our study was to assess the efficacy and safety of dexmedetomidine in reducing the postoperative pain in patients undergoing scleral buckling surgery. So it was a prospective randomized placebo-controlled interventional study done from July 2022 to April 2024 in patients who underwent scleral buckling with or without vitrectomy. The sample size was 105 patients with 35 patients in each group. So the patients with rhegmatogenous retinal detachment undergoing scleral buckling or vitrectomy combined with encircling silicone band were included, and this were the exclusion criteria. So the patients were randomized into 3 groups by block random sampling. Group first received local anesthesia, which consists of 4.5 ml of bupivacaine and 0.5 ml of normal saline. Group B was a DEX group, which received 4.5 ml of bupivacaine along with 0.5 ml of dexmedetomidine. And Group C was a placebo group, which received 5 ml of normal saline. So surgery was performed under peribulbar anesthesia, which was a combination of lignocaine and bupivacaine with or without adrenaline. Standard scleral buckling or vitrectomy with encircling silicone band post procedure was performed as planned. So all the patients which were included, they underwent scleral buckling surgery with or without pars plana vitrectomy. Study drug or placebo was injected in subtenon space at the end of the surgery after closing the peritomy. So the pain score was assessed using the visual analog pain scale. Systolic and diastolic pressure was, blood pressure was recorded, and the peripheral capillary oxygen saturation. These all were recorded at 1, 2 and 4 hours post-surgery. The sleep quality of the patient was assessed the next morning using consensus sleep diary. The patients with pain score more than 4 at any time post-operatively were given paracetamol IV infusion over 15 minutes, and the time at which patient requested for analgesia or when the visual analog score was more than 4 was recorded. Coming to the results, so age, gender, type of surgery performed and the type of explant used were comparable among all the 3 groups. So the patients in the placebo group, they experienced the maximum pain score at the time of rescue analgesia, whereas the local anesthesia group and dexmedetomidine group, patients experienced about the same pain score. However, the time to rescue analgesia for dexmedetomidine group was 304 minutes, was maximum as compared to local anesthesia and placebo group. Coming to the sleep quality, so the maximum patients in dexmedetomidine group experienced fair, good and a very good quality of sleep. Systemic parameters, so systolic BP, diastolic BP and peripheral capillary oxygen saturation, they did not differ significantly among the 3 groups. So out of the 3 groups, dexmedetomidine group experienced the longest duration for rescue analgesia, the lowest pain score and superior sleep quality. Coming to the discussion, so dexmedetomidine is a highly specific centrally acting alpha-2 agonist, widely used nowadays with local anesthetic mixture in peripheral nerve blocks, subarachnoid anesthesia and ophthalmic anesthesia. So what does the literature say? A study conducted by Eskander et al., they concluded that with the help of dexmedetomidine, the time for local anesthesia had a faster onset, longer duration and a higher sedation rate. Hafez et al. Also concluded the same results. But in our study, dexmedetomidine was given at the end of the surgery in subtenon space. The strength of the study is, it is a randomized placebo-controlled double-blind study. It is the first study to evaluate the effect of dexmedetomidine when given at the end of scleral buckling surgery, which is more painful than other ocular surgeries. And the systemic side effects of dexmedetomidine were also assessed. Limitations were that it's a limited sample size and subjective scale used for assessment of the pain. So I would like to conclude saying that dexmedetomidine is a useful drug when used as an adjunctive to local anesthetics at the end of the surgery. It may be considered as an option to achieve post-operative analgesia and retinal surgeries. Thank you.
Thank you so much for the opportunity again to present. Yes. So intraoperative fluorescein angiography in delayed postoperative vitreous cavity hemorrhage, POVCH. it is dispersed VCH post-vitrectomy for diabetic retinopathy, vein occlusions, or vasculitic vitreous hemorrhage. In the early immediate post-op, like in this case, it could be due to post-op clot dissolution or oozing stumps. But when it presents later, 6 to 8 weeks post-op, then it could be because of progressive neovascularization, traction, or anterior hyaloidal proliferation. In this case, it was mild, so it could be observed. However, when it is dense and persistent, it is necessary to do a vitreous lavage, which includes endolaser, retrolental blood clearing, base shaving, cryo to the sclerotomy ports, and silicone oil or gas tamponade. All these steps, however, are left to surgeon discretion. When we do too much, it could be an over treatment, and when we do just a fluid air exchange, it could be under treatment. So we wondered if we can do as much as necessary with as little as possible, like the Goldilocks rule. We wondered if IOFA could enable tailor-made treatment and avoid under or over treatment. Eyes with dense POVCH post vitrectomy for PDR or RVO were included with a minimum follow-up of 6 months. This is the accessory light holder in the Constellation Vision system, and we fitted a blue filter of 14 mm diameter into it. So this is the technique of IOFA. We injected 2 ml of sodium fluorescein intravenously, and you can see the arterial and the venous filling times in this patient who is undergoing a vitreous lavage post PDR. So here you can see in the mid to late phases of the angiogram that this very well delineated capillary non-perfusion areas are there here, and this is even an IOFA enabled endolaser. This is the characteristics of the purely digital barrier filter by adjusting the color, hue, saturation, and brightness. So on IOFA, we could find the arterial and venous filling times, active NVE, peripheral leakage near the aura, and the sclerotomy ports, and some novel findings as well. We had about 14 eyes with a mean age of 60 who had undergone vitrectomy, and we followed them up for 6 months. They bled about 75 days post vitrectomy. So this is a 69-year-old lady, known hypertensive and diabetic, operated for vitreous hemorrhage 2 years prior, who had a sudden rebleed. You can see the extensive CNP areas all over, and you can see delay in the venous filling. This is an IOFA-enabled endolaser. Now, if you look at the pictorial representation, this is the extent of the CNP areas we found on the IOFA. And you can see that there is only a central island of perfused retina. And you can even see the delay in the filling of this particular vein. This is a 55-year-old gentleman who had undergone vitrectomy for a BRVO. These are the CNP areas much beyond and posterior to the previous endolaser marks. This is an interesting case of a 68-year-old lady who had undergone vitrectomy with a well-lasered PDR. However, we found diffuse peripheral leakage near the aura in this case, and cryo was done to the ports, considering that this is an anterior hyaloidal fibrovascular proliferation. This is the last case showing that in the early AV phases itself, there were a lot of window defects at the posterior pole, suggesting an outer retinal and RP atrophy in this well-lasered PDR undergoing a lavage for VCH. This was a unique finding we found in our series. This is an intraoperative screen grab showing that this is unremarkable clinically. However, on the FA, there were large window defects. In literature, we have seen IOFA being used especially for CNVM, and the pictures that we have in the literature are very small field, and they are quite not that high on clarity or resolution. Our study used a purely digital barrier filter, whereas in literature, barrier filters had to be placed in the operating microscope and moved in and out. And we saw a lot of biomarkers for vitreous lavage on this digital assisted vision system, high resolution and pan-retinal fluorescein angiography intraoperatively. This can unearth novel biomarkers in patients undergoing a vitreous lavage and can give predictable results post-vitrectomy for diabetes and retinal vein occlusions. It can potentially reduce the risk of recurrences, reduce over-treatment or under-treatment by allowing only IOFA-enabled treatment during a lavage. Larger studies are needed to determine its true efficacy in vitreous cavity lavage. Thank you.
Thank you, Dr. Apurva. Is Dr. Naman? Yeah. So Dr. Naman is going to talk about characteristics of myelinated retinal nerve fibers and associated with Schachmer syndrome. Slides, please. Slides, please.
I'll be talking about characteristics of myelinated nerve fibers in associated Schachmer syndrome. The most common ocular syndrome linked to myelinated retinal fibers are Schachmer syndrome. It is characterized by unilateral MRNF, axial myopia, amblyopia, rarely associated with strabismus and nystagmus. MRNF is rare congenital anomaly appearing gray-white opacification with feathery margins in superficial retina, which leads to obscuration of the retinal and the choroidal details. In our study, the primary goal was to analyze MRNF cases continuous with the optic disc and study the relationship with axial elongation and visual acuity. The study's design was retrospective observational case series in a tertiary eye care in South India. The inclusion criteria was MRNF continuous with the optic disc, which was confirmed by a fundus examination and imaging. And exclusion were isolated MRNFs and poor quality images. The test we used was Shapiro-Wilk for normality and Spearman correlation test for MRNF size, visual acuity, and refractive error. On ocular findings, we calculated the visual acuity, refractive errors, and the intraocular pressure. In the MRNF, characteristics which we noted was type, which was 1A was superior, 1B superior plus inferior, and 1C was the inferior one. The size was measured using the optomap, and the posterior staphyloma was also seen. This is a type 1A case. Type 1B with superior and inferior MRNF, and type 1C, which was inferior. Using an area automated measurement tool, we calculated the area of the MRNF. Why the study was done? This study aims to fill the lack of large-scale MRNF case series in the recent literature. It explores the correlation between the MRNF size and the visual impairment. It improves the understanding of MRNF and its impact on visual outcomes, and it provides insight into the pathogenesis of Schachmer syndrome. On result, we noted that there was total of 19 eyes in 18 patients in which bilaterally it was present in one case. The median visual acuity logMAR was 0.4. The median intraocular pressure was 13.5. The most common type of MRNF which was noted as 14, and the mean size was 34.37 plus minus. There was no significant correlation which was noted with MRNF size. Axial elongation may not be uniformly affect the refractive error. MRN weakness retinal structure, as the larger MRNF can lead to greater elongation and amblyopia and poor vision. This was a chart which showed the correlation of the MRNF with visual acuity and the refractive error, where the refractive errors was not significant with the MRNF size. In conclusion, the MRNF size does matter, as larger MRNF can correlate with poorer visual acuity. Schachmer syndrome is the most common association with MRNF, characterized by axial myopia and amblyopia. For clinicians, MRNF size can help predict visual outcomes, and early management of amblyopia is crucial. For researchers, further studies with advanced imaging are needed, and larger cohorts can validate these findings. These are my references. Thank you.
Thank you, thank you, Dr. Naman. Can I have the next speaker, Dr. Sohani Patel? Dr. Sohani is going to talk about comparative analysis between Pegenex with focal laser with Pegenex alone in management of PCV.
Yeah, good afternoon, one and all. Today I'll be presenting comparative analysis between Pegenex with focal laser and Pegenex alone in management of polypoidal choroidal vasculopathy. So, as we know, polypoidal choroidal vasculopathy is a condition characterized by multiple recurrent serosanguinous pigment epithelial detachments and neurosensory retinal detachments due to abnormal aneurysmal neovascular lesions. Idiopathic PCV was first coined by Januzzi. It has a predilection for pigmented races. It is one of the pachychoroid spectra of diseases. It can be quiescent, hemorrhagic, or exudative. Risk factors include smoking, high BMI, raised CRP. There's also implicated genes are there. Um, Polyps can be unilateral, bilateral, asymmetric, and most commonly polyps are found extrafoveally and peripapillary. It's a chronic disorder with variable natural cause of the disease. It may remain stable, resolve spontaneously, or may cause repeated hemorrhages and exudation resulting in fibrous scar. Gold standard for the diagnosis is ICGA. In contrast, OCTA octa are non-invasive, fast, safe, and provides better resolution. Here's the patient, 37-year-old, presented with hand movement. As you can see, hemorrhagic polyp was seen, hemorrhagic PCV, and FFA and ICG images are shown with polyp leaking just near the fovea. This is the OCT showing notched PEDs, multiple. Thumb-shaped protrusion is also there. Double layer sign can also be seen. So objective, why we did this study? PCV comes under PSD, which also includes pachychoroid epitheliopathy, pachychoroid neovasculopathy. Out of all, recurrence rates among PCV only is the highest, and also we know that lesion reactivation in C is seen in PCV that almost occurs around 2 to 3 years after initial presentation. So here is one patient who presented to us with PCV. We gave Pagenes injection to this patient. So after follow-up, this was the OCT. Fluid was resolved, but the patient again presented to us after 12 months with reactivation. Treatment options only include thermal laser, VPDT, anti-VEGF, and combination therapies. Anti-VEGF agents are currently the first-line treatment, but at our center, we followed the pro-Renata regime, but high injection burden, non-resolving SRF, and high recurrence rate prompted us to attempt to go for thermal laser photocoagulation also. Material and methods. Study design, it was a prospective interventional studies. 15 pseudophakic eyes were taken. Those patients were diagnosed first for PCV. On OCT, we saw multilobular notched PEZ, dilated hallus layer, double layer sign, and on FFA, we saw hyperfluorescence, interconnecting channels, and there might be leakage from the BVNs also. And on ICGA, hyperfluorescent polypoidal lesions with or without BVNs were seen. Like this patient presented to us, as you can see in fundus photo, there is an orange-red subretinal nodule and corresponding OCT and FFA ICG image is also shown. Patients with symptomatic PCV having subretinal sub-RP, fluid exudation, hemorrhage were included, but if the patient had any history of taken focal laser for anything else were excluded. All 15 patients were given Pagenex, but if there was no improvement, then we took, out of those 15 patients, we took 8 patients for thermal laser photocoagulation also. Baseline screening was done. Thermal laser photocoagulation, extrafoveal polyps were only taken. They were ablated as they were identified on ICGA. Photocoagulation was done using argon green laser. This was the spot size. 120, 150 was duration. 100 to 50 power was there to achieve a grayish white burn. Antivascular endothelial growth factor was given. Main outcome measures was measured by SRF or anti-VEGF required. Results, 15 eyes of 15 patients were taken. 11 were male, 4 were females. Mean age was this. So in Pagenex only group, positive visual impairment was observed in 40% of eyes. In Pagenex plus focal laser, 75% improvement was seen. This is the comparative analysis. So these studies in literature also favored our study. Conclusion, study concluded the use of combined argon laser for management of PCV improves the visual outcome in 75% of eyes. So here are some patients, these pictures as you can see. This was the first presentation. We gave treatment and as you can see, polyps were almost ablated. After 2 injections, this patient presented for after recurrence after a year with hemorrhagic PCV. Then we did the focal laser and the polyps are ablated. This is the before treatment and here is the after treatment. Before treatment and after treatment OCT of another patient. This was the patient who presented us with a leakage at just subfoveal leakage of polyp, so we only said for observation. Thank you.
Verifying whether Dr. Hiteshi Jain is there, the last presenter. We were indicated that this paper is withdrawn. So the results of this will be tabulated by the scientific committee office, and then the semi-final winner will be announced. Now we will conduct 3 semi-finalists are there. Their names were Dr. Kavita, Dr. Prithvi Chandrakant, and Anupam Pragati Ras. Are they there? All 3? I am there. I have to upload. You upload, please. Did you rest of the 2 you uploaded your presentation? So, Asim is the first speaker.
Tasneem. Okay, shall I start? Good afternoon, sir. Good afternoon, everyone. My presentation is on analytical study of genetic polymorphisms on retinopathy of prematurity, progression, and regression. Conflict of interest nil, financial disclosure nil. And retinopathy of prematurity, as you all know, it is a disease of abnormal retinal neovascularization which affects the preterm babies. See, all preterm babies with the same risk factors not equally affected. Why not equally affected? That is the basic essence of the study. So we all know prevalence of childhood blindness in India is 6.5 per 10,000 children. And totally 3,20,000 blind children are there. And ROP accounts for the second leading cause of childhood blindness that accounts for 20 to 30% of childhood blindness. And in the treatment of ROP, we all know 86% undergoes spontaneous regression. And what happens to the remaining subset? So that's what you're going to deal with. And there occurs the genetic polymorphisms. That's in the phase of genetic sequencing in the retinal development, there occurs the inter-individual variations that causes the alteration in the structure and the level of proteins that increase the likelihood of regression or progression of ROP, which is contributed by these genetic polymorphisms. That is the mutation that occurs in the gene of VEGF, then tumor necrosis factor, then glutathione S transferase, angiotensin converting enzyme. The objective of study, as I told, analyze the genetic polymorphisms of the following genes on ROP progression and regression. And methodology, this is an analytical study. We included 100 babies, 100 ROP positive babies, and the study was conducted in the 2022 to 2023 December period in our hospital. Inclusion criteria, babies in all stages with mild, moderate, severe ROP according to IC ROP classification. And exclusion criteria, the babies having other ocular anomalies, systemic anomalies, under any medication, and not willing to participate in the study by the mother. And methodology, we have divided it into 2 groups. Group 1 is ROP babies with disease progression, and group 2 is ROP babies with disease regression. We collected blood samples from all the babies, and after getting consent from the mother, and we have sent it for analysis to our medical research unit in our medical college, and we have used the following techniques for VEGF and TNF and GSTP polymorphisms. We used polymerase chain reaction using the enzyme restriction fragment length polymorphism, and these 3 polymorphisms were digested with these enzymes. And for angiotensin converting enzyme insertion deletion gene alone, we used PCR and ARMS PCR. And coming to the demographic profile, The gestational age averagely it accounts for 31 weeks, and birth weight less than 1.5 kg, and most of the babies are male babies, accounting for 51%. And ROP classification, the babies in regression stage 34% and progression is 66%. And coming to the stages, the babies in stage 1 accounted for 37%. There is a majority. Stage 2, 35, followed by stage 3, and aggressive posterior pole ROP 4%. And coming to the analysis, allelic and genotypic frequency, we noticed a statistical borderline significance only in the VEGF gene. But after adjusting for the confounding factors, we noted a significant change in stage 1, stage 2 ROP with ACE insertion deletion genes and polymorphisms. So we have noted a p-value of 0.05 that is associated with the regression of ROP, and VEGF polymorphism associated with the progression of ROP. And this is the statistical analysis and result. And as I told, the ACE insertion genotype frequency was higher in stage 1, stage 2 regressing patients. And VEGF 936cc genotype, C allele and T allele was significantly higher in progressing ROP, stage 3 and AP ROP patients. And no significant differences found in TNF alpha or GSTP polymorphisms. And comparison with previous studies, see, it was the first of all Indian study we do the genetic polymorphisms. And only in other countries, they have done the genetic polymorphism studies. And India, we have done only a meta-analytic study. That is, we have done analysis for prevention of ROP only from the journals, not in live. So this is one of the first study we have done in our Indian population, so which we have found the AZ-ID polymorphism associated with a decreased risk. So what I have like to conclude is this genetic polymorphisms could play a role in susceptibility, progression, regression. So we can have a guide of the proper development of targeted and early treatment for infants at risk of progressing RP, thereby preventing blindness. These are my references. Thank you, sir. Thank you all.
So good morning, everybody, and thank you, judges and AIOC, for this opportunity. So I'll be presenting on the GLOW study, which is the utilization of an illuminated vitrectomy trocar cannula in the real world. So no financial interest in this presentation. So as you know, vitrectomy requires multiple exchange of instruments, requires change between the cutters, the cutter, the forceps, the cautery. Can you play the video, please? Yeah. And endo laser, and sometimes in complex cases things get difficult. So you need a frequent instrument exchange and a fast instrument exchange. So when you switch off the microscope light to to change your instrument, you really cannot see the trocar. And in situations when there is excessive bleeding, you require a cautery to enter fast. So when the light switched on, you cannot enter really fast into the vitreous cavity. So to overcome this, so this was our problem statement, where you put when the microscope light gets switched off, you need to switch it on again, go in, then again switch it off. So this was the issue here. So constant illumination was not possible, and the light required to be repeatedly switched on and off. So our aim was, so we developed these glow pot rings, small illuminated rings, which emit phosphorescence. So we use that to evaluate in the real world the experience of VR surgeons utilizing this, and we asked them to compare, incorporate in their standard practices in VR surgery. So this was the glow pot. So these are illuminated rings with strontium aluminate in them, which emits the phosphorescence, totally inert to the and non-reactive with human tissue. So it's fitted over the 25 gauge trocar cannulas like that, and then you can use two of them, put it in both the trocars, and you can insert it. So one is the infusion, then two are for the instrument insertion, and you just use your endo illuminator, just illuminate it. So once you illuminate, you can start your vitrectomy, illuminate with the continue illuminating it with the endo illuminator. And then once you switch off the microscope light, you can see that it kind of glows in the dark, and it stays for around half an hour. So this is the illuminated vitrectomy trocar cannulas, which helps in guiding your instrument into the vitreous cavity. So we required feedback from various surgeons. So it was a retrospective multi-center feedback-based study involving 7 vitreoretinal surgeons who utilized the glow pot in their surgical practice over a period of 1 year. So we asked them to assess their task completion time. If they are not able to do it in the OT, to see their surgical videos and do it, retrospectively go back and see the videos and do it. And then we also gave them a feedback questionnaire as to how good it is. So we calculated it using the aggregated quality score. So very poor, acceptable, or excellent. So we divided it into 5, what all you can do: visualization and precision, safety and complication prevention, ease of use and ergonomics, durability and reliability, and cost versus benefit. So based on this, each category was rated 1 to 10, and these scores were multiplied by the weighted percentage, and then we, some of the weighted scores, we got a final score out of 10. So 7 VR surgeons used the Glowport in 200 patients for a period of 1 year, and then this was the scoring. So visualization around 9, they were happy with the illumination, and they did not have to keep on switching on and off the light. So it was safe, there was no trocar misplacement or anything. It's ergonomic and easy to use and insert. Its durability, it's a little bit subjective. So some said that, we don't know how much after ETOing it will run, but then it was pretty okay. And cost versus benefit also, it's extremely cheap, around 50 rupees for a piece of 2. So this was the final score we got of 8 out of 10. And the main important, it reduces in mean time to task completion, which is reduction in the time for an instrument exchange and not switching and not repeated switching on and off of the microscope light. So limitations were there. If you are doing combined surgery requiring manipulation of the superior conjunctiva, then you cannot use this Glowport. We are working on reducing the diameter, and the time comparison for instrument exchange with and without Glowport should ideally be done in a controlled lab setting or a mesopic setting. So to conclude, this was a 3D printed, frugal, inexpensive, reusable tool which improved surgical efficiency and improved the instrument exchange, reduced ocular touch errors, reduced the procedure time, and the subjective feedback from VR surgeon highlights its potential to enhance the visualization and is beneficial for both experienced VR surgeons as well as neophytes. Thank you.
Dr. Pragati Ras.
So, I would like to invite the last speaker, Dr. Pragati Raj. She's going to talk on wide field ICG in pachychoroid disease, a comparative study with normals. Slide, please.
Good afternoon, everyone. So my slide is not changing. Good afternoon, everyone. My topic today is a comparative study of wide field ICG angiography in pachychoroid diseases. There is no financial interest or conflict of interest. So we already know is pachychoroid includes choroidal thickening with dilatation of Haller's layer and attenuation of vessels in the Sattler's layer and the choriocapillaries. So our study mainly concerned with the what causes the pachychoroid phenotype and why same pachychoroid phenotype gives rise to different clinical presentations. The spectrum includes PPE, where there is, along with other pachychoroid features, there is RP defects, CSCR, where there is NSD because of hyperpermeable choroid, PNV, where there is type 1 CNVM, and PCV, where there is aneurysmal type 1 CNVM. So this was a study for the choroidal vasculature changes in pachychoroid disease using wide field ICGA, and it was a cross-sectional observational study with institutional ethical committee approval. Along with clinical examination, the diagnosis was made by OCT, where the subfoveal choroidal thickness was taken as 300, and any patient with prior history of treatment or inflammatory choroidal condition were excluded. Wide field FFA was done, and ICGA was done on Mirante machine, and analysis was done by 2 independent observers. So there was a male preponderance with a mean age of around 40 years, and included 15 neovascular PCD and 25 non-neovascular PCD. The vision mainly was better than the 618. This graph shows that amongst the neovascular PCD, the macular polyps predominantly were seen, and in non-neovascular PCD, chronic active CSCR patients were seen. These are the prototype case where this is acute CSCR with SRF, ink blot leakage on FFA along with NSD in OCT. This was a chronic CSCR with gravitational tract and classic teardrop sign with shallow SRF and RP defect. This was apparently normal looking fundus with few microaneurysm with pachyrusin seen on OCT. And this was an exudative maculopathy where there was leakage, leaking polyp as well as the staining with tall notched PED seen on the OCT. This is not what a normal vortex vein distribution is, where their vessels are of almost normal caliber, maintaining a physiological watershed zone. But we found in our cases there was asymmetric vortex vein distribution where one of the vessel was draining more of the choroid, and it was identified in the early phase of angiography. This was also, we found the dilated vortex vein in the early phase, which had posterior extension towards the peripapillary region or the macula or both. And intervortex anastomosis, that is the loss of physiological watershed zone, and it is suggestive of vascular remodeling. Choroidal vascular hypopermeability seen in mid to late phase, and it correlated with the dilated vessels or the intervortex anastomosis, and it correlated also with the leakage and the window defects. So what we found was that there was 100% CVH seen in both acute as well as chronic CSCR cases. But in chronic CSCR, we also found this other signs of vascular remodeling, that is vortex vein asymmetry and anastomosis. But in neovascular pachychoroid, we found there was intervortex anastomosis seen predominantly. So what we concluded was that the vessel abnormalities or remodeling that led to the congestion and then the posterior extension with anastomosis, and the excessive flows through these vessels caused the RP defects, and these were more pronounced in the chronic active cases and ebb to tend away, resolve away in resolving cases. So this is what we already knew about pachychoroid spectrum, but after all the studies outside India where they found alteration in the venous choroidal veins in the pachychoroid disease, we also found that the chronic active PCD has choroidal changes, that is a global problem, and increased instances of IVA in neovascular PCD suggests that the congestive features are ebbed away, but RP defects and the oxidative stress becomes trigger for the neovascularization. So this study could help in understanding and monitoring the treatment provision and also streamlining the treatment protocols, and subthreshold laser in all zones of the distended veins and intervortex anastomosis can be done, and targeting the dominant veins in case we go for the scleral windows creation by surgical process. And also the limitation of our study was about this population, which was a multicentric study with large number of cases would be beneficial. Standardization would increase the objectivity of the study, and ICG at successive follow-up would help in the monitoring of the disease. Thank you.
Thank you all the presenters. The scores will be sent to the scientific committee office. These include the retina semi-finalists also. The results will be tabulated and will be announced by the scientific committee office. And the session is now concluded.
The photograph. Speaker.
हमारा ले सकते हैं स्पीकर तो निकल गए
अच्छा ठीक है हाँ okay so the speakers of the session who are here, please come here, please come on the dais for the photograph.